Hi, my name's Brett. I'm here to talk to you about how to do shoulder assessments and how we document those. We'll get started on a couple things to know before doing shoulder assessments. We want to make sure when you see the patient, you consider mechanism of injury involved, because sometimes injuries can involve C-spine and other things that we're more concerned with than the shoulder. So we're not going to really get too much into cervical assessments. That can be viewed in another section, but this one will be mostly focused on just shoulder assessments. So with shoulder assessments, the first thing we're concerned with after we rule out cervical concerns is, do we have dislocation? And we want to rule that out before we go into manipulating further causing injury to blood vessels and nerves. Intense, severe pain. You'll notice disharmony, so it'll usually have kind of a dropped shoulder appearance, and the inability to lift or move that arm. Most patients with a shoulder dislocation will present guarding that arm or trying to lift or hold that arm in place. They have numbness or tingling through the arm, and they'll also usually have an inability to move the arm. Hardly because it's not solid, and it may have muscle spasms in the arm or the shoulder. The concern of the muscle spasms is if we try to position them for comfort, they may not be able to achieve any comfort. This is because of the contraction of the muscles causing further pain. If we run into any of these things, the course of treatment is generally to try to split or immobilize the sling up as best as possible that the patient tolerates, and so we're able to refer them to a higher level of care. In addition to immobilizing the arm, we can provide treatment by giving them some sort of ice to control inflammation and swelling, as well as a medication that will also help with pain and inflammation. Fortunately, most of the times you'll see a shoulder dislocation is not going to be the patient's first time ever having one, which is generally helpful to us. They usually tell us, hey, it feels like my shoulder's dislocated. I know what this is. If you ever hear that, it's usually a safe bet to kind of agree with them and treat as such. Once we've ruled out any concern for dislocation, do you want to kind of generalize shoulder assessments? What you want to do to start is track out the patient's history to rule out if had any sort of shoulder surgeries, prior shoulder injuries, and you a little bit of a clue as to maybe what's going on at this time. First, we want to do if a patient's really unable to, this has to remove their shirt. This does two things. One, it allows you to visualize the patient trying to take their shirt off, which uses a lot of shoulder movements on their own, and gives you a sense of how critical or severe the pain is with moving or utilizing your shoulder. And two, with it off, you're able to then visualize the shoulder and note any abnormalities, bruising, swelling, redness, anything that might be to get further injured. Next, you'll want to ask the patient to kind of indicate where exactly they feel pain if they can. Sometimes it's a generalized sensation, other times it's very localized. Be able to pinpoint directly where they have pain. It helps with targeting more specifically what may be injured. Now, in asking them to localize or describe the pain you want to get, quality of pain is aching, burning, stinging, tingling, sharp, whatever kind of word they want to use to describe it. And then we also want them to tell us if it's radiating or just in one specific point. So again, you just want to get as detailed information as possible. So first is we want to do is ask them to use an upward range of motion unit. So those are going to be forward flexion all the way up, abduction all the way up. We're going to do external rotation. We're going to do cross body adduction and abduction. And then we do extension and unilateral rotation. You'll want to note through any of the ranges of movements if they have any limitations or when pain begins and ends to get an estimated degree range. So, for example, an abduction extremely 0 to 180. If they get to about 60 degrees where they have pain and they're able to continue going. And then they don't have pain. That's significant because that could just be shoulder attachments. And that's limited to that small movement. When you know that 360 and 120 degrees, they have pain. Also, in terms of like body motion and movements, if you're able to go over the head and not have to compensate, that's perfectly fine. But we want to notice they do anything like shrubby to try to get their arm up more. That will indicate they have some level of weakness. You'll also want to note if they have any inability to keep motion. So, say, for instance, they're able to pull forward flexion motion, or they can't abduct at all. Just know the limited range of motion or inability to play motions. Other things to consider when assessing the shoulder is work having to a circle assessment first before this. There's also a potential for bicep to be involved in shoulder pain. And it's you put a little out there, it's more bicep isolated versus shoulder isolated. What things we do for that is just basic resistance deflection. If they have strain through the origin or insertion but to bicep, it's probably more of bicep strain or tear. Another way you can do is have them try to supinate their hand, but resist their hands turning. And then the chest that isolates bicep. The main point of a lot of our nursing assessments is really going to be to determine whether the patient's go to high care or evaluation treaty. The indicators of that are usually going to be one of neurological involvements, such as numbness, tailing, obvious deformity, severe ache, and abilities. The other main reason for our literacy assessments is to generate a baseline for injury compare visits to. So, for instance, if the patient's initial visit, they run in with the abducts at 45 degrees and some pain restricted further movement, they could go treatments. They come back, you see them again, that equal now to go to 90 degrees. Great, you have some null include we can compare sausage. If you're not descriptive with degrees of movement, there's no way to really compare how all the patients are hungry. After you completed all of your assessment, of course, then coach treatment, whatever you can do. Which you can remember pretty much for a day only isn't much, but we can do something. Generally, that's going to be ice. Your follows race therapy principles. We're going to try to get it cold to reduce lung inflammation, and we're going to try to get them some sort of open medication to help it. Make sure you're detailed in how you document the ice. Make sure you put 15 minutes, 20 minutes on what's to your shoulder, posterior shoulder, and how much medication you need. And then you want to note after treatments if they had any improvements from the treatments we did or if it's already necessity. And then after treatment, of course, we're going to recommend follow-up applications. Generally, for most shoulder injuries where we're concerned that meaty muscular, we're going to try to follow up at least the next day, which is bill day, to monitor that's progressively got severely worse, or for kind of where we started on, and then from that point on, you can use a 2 to 3 day assessment. And to cover a little bit more in depth on the different assessment techniques, tests, we can do things like the can test, but that is by you do that, you can follow on train walk is be by a sports science medicine doctor that is for Stanford that does a great job seeing all the anatomy of the shoulder, how does different movements interact, and kind of dictate a little bit more clinically and diagnostically exactly where in the shoulder person's injured. It's good for us to know that nothing we necessarily have to use the diagnosis with. Hopefully this was helpful in learning how to do shoulder assessments. We need to make sure it documents. I appreciate you guys watching. Take care.